Okay. This last session is a brief session where I've titled it Moral Agency. There's a couple of ideas I want to get across. When I covered double effect, I talked about the causal chain. And one of the issues in being a causal chain is that there is often an action, and whether you're a moral agent, whether you're involved in some sort of moral action is important in that. So we covered that a little bit in double effect. We also covered it in a physician-assisted suicide and voluntary active euthanasia. And if you remember, I contend this is an agreement with people like Tim Quill and some of the right to die people, even though I think assisted suicide and euthanasia are evil. I do agree that both are very similar moral acts. That if someone asks for assisted suicide, says, please help me take my life, and you give a prescription, here, take this and you will surely die, and it's not much different. You're morally culpable for that action. You're a moral agent. You're making a moral choice to engage in hastening someone else's death. It's not much different than if you give that, if someone says, please, doc, help me take my life, and you give that injection. Both you're morally culpable. I think in most philosophical and theological systems, you're equally morally culpable. The distinction between voluntary active euthanasia and physician-assisted suicide, there's two potential distinctions. One is kind of the concern of the patient changing their mind. That if they have to push that button or take the lethal dose, they can change their mind up until the point they make the decision, or until they take the dose, where maybe if you give it, if a physician gives it or someone else gives it, they can't change their mind the same way. I don't think that's as big of an issue, really. It's really about the way the law is written, and whether you're an accessory to murder or the different types of manslaughter, who pulls the trigger, it makes a difference. Suicide versus homicide is a distinct category at law. So I think you're a moral agent in either. And I want to just make a few comments on moral agency. We talked about the kind of ideal relationship of physician and patient. I'm going to be egocentric physician for simplicity's sake and just say physician. This can be interdisciplinary care team. It can be a DO, not an MD. It can be a nurse practitioner. It can be a social worker or counselor. Lots of different things. I'm using the physician-patient model because it's the one I know the best, and it's kind of a heuristic for many other clinical models. And the shared decision-making is the physician being an expert in medicine, the patient being an expert in self. Too often in modern medicine, and I said this during our decision-making session, we try to make the patient an expert in medicine. And too often we may think that the physician should be an expert in the patient in a way that they're not, including the moral values, things like this. There should be this interchange that of a shared, that brings shared decision making. Okay. So that's one concept that's our basis. Another is my suggestion in the 4-box model. You have medical facts, you have 2, 3, and 4. And in 2, remember I've modified the 4 boxes to say patient and professional preferences. Because Siegler, Johnson, Winslade assume that professional preferences exist in this medical indications box, this medical facts box. I think some of them do, what their guidance is, what they think the best evidence-based medicine is, but sometimes it's a moral question. I don't want to let a drug abusing patient go home with an IV, or I don't think I won't refer for assisted suicide. I won't turn off the pacemaker. Things like that. These professional preferences sometimes are one of the big issues. And there's a question as, does the professional get as much clout, as much attention as the patient's preferences? And I think they should. I think the liberty, so any concept of moral culpability doesn't say, well, I got permission, therefore it's okay. I mean, that's an autonomy ethic only, a permission ethic only, that says if I have permission and it's legal, then the professional must do it. Julian Savulescu, one of the heads of ethics at Oxford, famously has been saying, if any professional is not willing to do all that is legal, they should be exited from the profession. That's making law, which is really the basement of what's ethically permissible. It makes it a claim right, that anything that is permissible can be claimed by the patient and the professional, and in order for them to continue as a professional, can be forced to comply. And the challenge of this is that people are so emotional over things like the abortion debate that they think everything hits that debate. But but a lot of these conscientious refusal questions are very controversial. The issues around them, there are things like abortion, things like gender reassignment, things like assisted suicide and active euthanasia, things like palliative sedation and not refusal for artificial nutrition and hydration. It includes all those things. It includes many other things potentially as well. There are times that professionals can say, I recuse myself. I don't want to participate in this because I don't want to be morally engaged. I think there are limits to that lack of, to the conscientious refusal. But any idea of moral culpability, of moral agency, is going to say that if a physician or a clinician of any sort, if a professional prescribes or gives the treatment, so by action, by counsel, even in many moral systems by silence or by praise, these are all the ways that one can become morally active. There are several others, but these are some of the more common. This is kind of the traditional ways one can sin. Well, it's also in many philosophical systems. This is how you can become morally involved in the chain of events that leads to the outcome. In an ethics that's just outcome based, it doesn't. Moral agency is considered in various ways. But in medicine, we really should at least take the differences in different philosophical and theological positions and what in ethics seriously. And if someone is morally culpable for an action along the way, I think that they should be defended. So I am for kind of the right of conscience, or you can also say conscientious refusal or conscientious objection. Those are loaded terms because sometimes they show which side of the argument you're on. Lots of conscientious objectors in the military. Now they had to pay a price for being that. And some ethicists say, well, physicians have to pay a price if they're going to do that as well. I agree. It means that they probably won't be able to treat that patient. But I want to take you through some of the practical ideas about conscientious refusal. I will use myself as an example. I'm a physician. I've treated lots of patients in end of life. I'm opposed to assisted suicide and voluntary active euthanasia. I've been asked many times to participate, even in states that it's illegal. I've always said no, but I've always said why. What's your concern? Sat down with the patient, gone through those things. And to my knowledge, I've lost one patient who was actually interviewing me in advance to see if I was the right doctor for him because he wanted to be euthanized, and I wasn't. But I've never lost an active patient that I know of. They've never left to go seek out another physician that will help kill them. And to my knowledge, no patient has taken their life. They haven't. We've been able to work through the concerns without resorting to that. Now, if I were in Oregon or in a state that allows assisted suicide, I feel that it's wrong. I would not want to give a prescription. I surely wouldn't be involved in active euthanasia or palliative care during a suicide attempt. I would not want to give counsel that this is a good idea or that this is how you can get it. I would not want to stay silent. I would actually want to say, no, I think this is bad for you. And I sure wouldn't want to give praise, oh, I'm so happy for you. For me, that would be violating what I think is good and right. But it's not just to cover my moral backside, my moral hide. I am actually caring about the patient in that. I think assisted suicide is bad for them. And that's what I would share. In a kind way, if people are insistent, and if I were in a state where it was legal and permissible, I would just share, I think this is bad for you. I'd like for us to explore other ways of dealing with your fears. So what we really have in conscientious refusal often is varying views on what health is. And medicine, which was the treatment of disease, trying to bring to healing and cure, at some point in time tried to shift to healthcare. It's not very good at that, but all of a sudden health and wellness. Well, these health and wellness definitions get broader and broader, where all of a sudden wellness is about doing yoga and mindfulness meditation, specific Buddhist practices or Hindu practices, and that's peculiar. Why that definition of health? One may say women's health includes the right to contraception and abortion. Well, some would say, well, that's not healthy at all. Some would say that health is compassionate symptom relief at the end of life without hastening. Others would say, no, that's not validating autonomy and helping people choose the right to die. So we have these varying definitions of health. This is, I think, even from a secular sense, because we don't agree on what the goals of health is, what health is, what wellness is, especially in states of disease. We don't agree on the basic values. I think in the pluralistic society, one of the things to honor is a conscientious refusal. Now, there are some limits to this. If I have a physician who's a Jehovah's Witness and will not prescribe blood, I can't be my trauma surgeon, my hematologist, or my ER doc in a secular system. Now, I can imagine a Jehovah's Witness hematology practice. That this is a hematologist that serves Jehovah's Witness patients, and he's a Jehovah's Witness too. I can imagine that. I don't know how they get trained, because I wouldn't want them training at my center and wouldn't allow it if I were in control of such. But I can imagine such. I couldn't have a palliative care doc who won't prescribe any opioids. I mean, there's just some limits. So just because sometimes there are consequences to conscientious refusal, it doesn't mean that you can refuse anything. So as a story, I'll tell you, in the 1990s, during the HIV epidemic, before the advent of of multi-drug therapy that's far more effective for HIV, it wasn't uncommon for people to refuse to care for patients with AIDS. Now, one of the reasons they may refuse is because they were afraid of contracting the illness. Okay, maybe that was misinformation, maybe it was just the information of the age, but other reasons were some of them that they were blaming them for their own disease and the lifestyle that they led, and there were a host of other kinds of discriminatory practices that I don't think are defensible. If I had a physician in my system that was saying, I won't treat HIV patients, they wouldn't get privileges. That's not an acceptable conscientious refusal. Now let's compare that to, say, Ebola. I was on an action team for our health system when the Ebola outbreak was happening. We had a few scares that made the media, and we had a very clear way of dealing with this epidemic, this Ebola scare. We weren't going to force, because if you care for a patient with Ebola, an outbreak, you're going to be quarantined for a number of days. I think it's 21. We didn't want to force, in a time of great fear, force our staff and physicians to care for Ebola patients. So we asked for volunteers. We didn't even ask, and we had tons of volunteers. We had more than enough people for our at least initial 2 or 3 waves of response if we had an outbreak in our area, our region. If it was a huge outbreak, we would have had issues. But for the first waves, we were fine. And of course, since things didn't get as bad as we had feared, we had plenty to care for the few suspected cases, and they were very few. So in Ebola, we took volunteers. Now, if you imagine, people could say, "No, I can't. I can't care for an Ebola patient. I'm a single mother nurse. I can't be quarantined for 21 days." That's a legitimate refusal. It's not really conscientious. It's practical. If they said, I can't because, they shouldn't travel to Africa and I'm judging them, that may be different, but I don't think that's going to happen. So I do think one of the things historically about the HIV issue, which I think is a challenge to conscientious refusal, because there were some really atrocious things that happened during the AIDS epidemic, is if we compare it to Ebola, and the fear around HIV was not quite as high, but it was high. I think some of the things that happened during the HIV scares are more understandable if we compare it to Ebola. Now again, if I had a physician or a clinician that said, "I won't treat HIV patients," that's a problem. It's like if even really controversial topics like transgender and gender reassignment. If I have a physician that says, "I won't treat transgender patients," and we're a public secular system, that's a problem. If I have a physician that says, "I won't do gender reassignment," okay, that can be allowable. So I encourage you to consider this idea of moral agency. Just because some ethicist or some policymaker, just because Medicare, Medicaid allow it, just because the Department of Health and Human Services or the Institute of Medicine or any of these groups say that's permissible, doesn't mean that the professional has to be forced to act. This is going to be a huge issue over the coming years. And I'm afraid that the trend will be to squash rights of conscience to a very specific cosmopolitan liberal ethic. Now I use cosmopolitan and liberal in their proper definition, not their common definition. But to a very specific ethic, and that was not going to take diversity seriously. So this is just for your consideration. Thank you for listening.